Evening, everyone. Thank you very much for joining. And today we have got two of the best speakers of India, and they're well renowned. And they are most popular because of the way they explain things and make things more simple. I have personally attended many of their sessions, which is extremely good, it's rational, and very practical. So, and today topic also needs such type of speaker who makes things simple and easy, so that it is applied in our day-to-day practice. On behalf of NNF Karnataka State Chapter, I would like to welcome Dr. Rama Rao. He is the Chief Neonatologist Director of, sir, may I know your hospital name, sir?
Andhra Hospital is there in the name.
Yes, sir.
Andhra Hospital Center.
Andhra Hospital.
Yeah.
Thank you very much, sir, for joining. Request to be a speaker for today. And followed by his talk, we have Dr. Seshagiri from Vizag. And he is a well-renowned person, and he has been phenomenal in taking care. Sir, you are from Vizag, so very popular over there and even across the country. On behalf of NNF Karnataka chapter, we would like to welcome you. I would request
Dr. Prashant,
a few words.
Dr. Prashant, both are
Yes.
Dr. P V RAMA RAO is known as an Andhra Pradesh. What is it? His hospital is a AP's. They will give the what is that advice to the AP government. And in Andhra Pradesh, many places, because of Dr. P V RAMA RAO. PV means Venkat Rama Rao Paturi. In his names, there are so many streets are there.
Oh, come on.
They are dedicated people. They have taken so many villages under their hospital. They are doing free of cost service. Number one. Number second, I think so. One picture actor, hope so, Mahesh Babu, has requested them to take care of all poor children for the cardiac problem. So they are doing almost free of cost so many cardiac operations. He is calling from UK, I think so, or America, many cardiac doctors, and he is doing free of cost operations. And more than anything else, he is dedicated man and very simple. Okay, number one. And his accent still remains to be still Anglo-Indian accent. So we should adjust with him.
Not like that.
We should adjust with him. And Dr. Seshagiri, sir, you are working in Giggle, sir?
Giggles Hospital, sir, Women and Children Hospital. It is Omni
And
RK.
he has
It is named after the father of pediatrics in this area, Dr. Radha Krishna.
And Giggle Hospital, it's a huge hospital in Vizag. And he has given a beautiful brochure about the hospital, what all he is having. And he is heading that neonatal unit. And more than anything else, I think so. Sir, you are the first DM neonatologist in Vizag.
For divided Andhra Pradesh, for that matter.
Yeah, of course. See, this is the one. So on the AP, you are the one. I think so. Even what is that? One more person name. Our
Sunil.
first one. Sunil. Yeah, Sai Sunil Kishore. We know. So welcome to you people, sir.
Thank you, sir. Thank you.
And your allotted time is 45 minutes for each speaker. I request you people to hold all the audience till the end, because people should not go out. Prashant, right now, ask all the audience to, in case, and whom they should type the question. Is it for the co-host or you directly?
Sir, they can direct the question either to you or to me or to host. They can what?
Okay, 1 minute. Make them very clear. You can give the questions to Dr. Prashant Gowda or Dr.
Yes,
Dinakar.
sir.
They can
Dr.
type
Dinakar,
right
Dr.
now.
Dinakar. Yes, sir.
Okay, Dr. Dinakar, they can type to me. He is opening the port to me. You can type it after any doubt. You don't think if I'll ask that question, they will feel bad, or because we are all coming in the same boat, and at present sailing also same boat. Over to you, sir. Rama Rao, sir, please.
Okay. Thanks, Andy. Thanks to Dr. Prashant Garu and Dr. Dirika Garu. Thanks for kind introduction. I don't know. I deserved for that words. And I know that all of you are facing difficulty, in COVID-19. It's really a hard time to all of us. Somehow we are managing. And as far as the children are concerned, it's not a big problem. And the children are also getting infected, but not that many positives, not that many sick children. And I'm also a state COVID-19 expert critical care member, and also I'm also in the technical advisory committee, for COVID-19. But just beware of that. Before I start my talk, just beware of the pediatric multi-system inflammatory syndrome. You all heard, I think, PMIS. There are a number of cases reported in US and also UK and other European countries. They are presenting with atypical Kawasaki features or with features suggestive of toxic shock syndrome. So, so when you see children, sick children, just to keep that in mind and then manage accordingly. So back to the topic. So today my topic is high frequency oscillation in clinical practice, mainly in the recruitable lungs. I'm going to concentrate on just on the practical aspects, and it's all evidence-based medicine. I think you already had talk on physiology, so I'm not going to touch on that. So mainly clinically, how you manage a baby, when the baby comes to your unit, and how and when to go for oscillation, and then a bit of evidence as well. So, evidence-based medicine. Evidence-based medicine is the integration of your individual clinical experience with the systematic research. This is for postgraduates. So we are practicing evidence-based medicine. So I think let's go through some of the scenarios, and also we'll also look at the evidence. These are about hospitals.
Rama Rao sir, one request, sir. Can you please closer to the laptop, sir? Closer, so that the voice will be very clear.
All right. Okay. Just
information in the voice, sir.
Okay,
yes,
sir.
Sir, yes.
What about now? Can you hear me? Hello?
Yes, sir. Sir.
Is it clear now?
Yeah, better, sir. Better. Clear.
Okay. So let's go through these scenarios. High frequency ventilation. So in that, here the frequencies, you all know that one frequency is equivalent to 60 per minute. The volumes, tidal volumes are very less tidal volumes in high frequency ventilation as when compared to conventional ventilation. So basically, in high frequency ventilation, uses low tidal volumes and constant mean airway pressures and high respiratory rate when compared to the conventional ventilation. So these things have beneficial effects on oxygenation and ventilation. So I really like this slide. Here, the pressure volume curve, everybody knows. I'm not going to details, but in this main thing is you just look at the curve, that is pressure and volume. So what we want is like walking penguin. So walking penguin and falling penguin. So let's imagine walking penguin in this pressure volume loop. Walking penguin is here. If you interpret that one, it is basically lower pressure and optimal volume. That is walking penguin. That is standing penguin. If it is falling penguin, means we are using more pressures with less volume. So we don't want falling penguin. What we want in this pressure volume curve is standing penguin. So just compare that. So important concepts in oscillation. So in that, main thing is that recruitment is very important in this. All-wheeler recruitment happens here. We'll discuss how it happens. I think you already had talk on physiology. What happens in oscillation, and then oxygenation and the carbon dioxide clearance. These two are very important. So anyway, oscillation is not that difficult to operate in your neonatal intensive care when compared to conventional ventilation. In conventional ventilation, there are so many modes are there. So you need to look at so many things. So when you change the ventilator settings, but in oscillation, there are only 4 knobs you need to manipulate actually. So it's not that difficult. So once you try, it's easy to operate oscillation. So in this, mainly 2 things only. One is oxygenation. Second one is carbon dioxide clearance. So oxygenation mainly depends on map linear wave pressure and FiO2, whereas carbon dioxide clearance depends on frequency and amplitude. So let's see. So this is gas transport studies. I think you already had talk on physiology. So what happens in oscillation is, here is the direct alveolar ventilation, and then it's a molecular diffusion in the alveolar capillary membrane, and then convective mixing of gases. So that's what happens in oscillation. I'm not going into the details. You already had talk on that. Next one is here. Just when you increase the tidal volume, increasing tidal volume is more effective than increasing frequency. So when you decrease the frequency here, what happens is there is increase in tidal volume, and there is a better clearance of carbon dioxide. Oscillation operates by using piston mechanism. You already know that is a to and fro application of pressure to the airway opening, and there is a continuous delivery of pressures when compared to the conventional ventilation. So when you decrease the frequency, it increases the tidal volume. We'll go into the details about that. So in oscillator settings, let's go to the clinical one, purely clinical one. So what you do? So babies on conventional ventilation needing higher pressures, then you will decide to go for oscillation. Then what are the initial pressure settings on oscillation? So what we normally do is we'll keep 2 centimeters of water above the conventional ventilation. For example, if the baby was needing about 16 mean airway pressure in conventional ventilation, we'll start with 18 in oscillation. Frequency, it depends. So usually we'll start with 10 frequency and we'll go up to 15. What are the indications, when to go for oscillation? Oscillation. Mainly it's respiratory, as you all know that. There are a number of indications are there. In that, the first one comes in initial ODS. In that, the first one is the STLD, that is surfactant deficiency lung disease, meconium aspiration syndrome, pneumonia. And other indications are congenital diaphragmatic hernia, PPHN, and ARDS. And so oscillation is also useful when there is major pulmonary barrier trauma, and that is in airlake syndromes and bronchopleural fistula, and it's also useful in PAE. So let's see. This is the one artificial oscillation in meconium aspiration syndrome. This slide is. You could see the oxygenation index and also lung injury score. Look at the first one and then look at the last one. So the oxygenation index is less when you combine oscillation with also surfactant. The oxygenation index is less. So in the lung injury score is also less when you oscillate the baby with, for example, in meconium aspiration syndrome. When you get the surfactant, the lung injury score is less when compared to the other ones without surfactant. So let's go to the scenario. So this is a child baby with meconium aspiration syndrome. So the baby was on conventional ventilation. So initially on pressure control. Initial settings, the baby was needing higher FiO2. Nearly 100% FiO2, needing higher pressures. So let's say that 20 over 5 pressures and rate about 50 or so. Then ABG, arterial blood gas showed respiratory acidosis with the pH of 7.23 with the PCO2 of 55. So what you do? PaO2 is around around 70 or so. So there is a respiratory acidosis is there. Baby was still baby was on higher ventilatory settings, needing higher pressures and then higher FiO2. Then what is the strategy now? Now the strategy is, you have oscillator in your intensive care unit. Then the option is to consider high frequency oscillation. Okay, then you decided to go for oscillation. Then what are the initial settings? So initial settings will be, as I was told, there are only 4 things you need to manipulate. That first comes is frequency. You usually will start with the frequency of 10. And then mean airway pressure, as I've already told, that will keep 2 centimeters of water above the mean airway pressure on conventional ventilation. And then amplitude. Amplitude normally will keep it around, if it is a term baby, we'll keep it around 35 or 40. Usually it corresponds to the gestational age, not necessarily all the time, but it's a kind of rough guide. Is maybe you could start with term baby 35 to 40 amplitude and then work on that. And then FiO2, depending on the requirements, initially will go we'll keep a higher FiO2, and then we will, once we work up the pressures, we will be FiO2 slowly. So that is the initial ventilator settings on oscillator. Then so we repeated blood gas after 1 hour. ABG was showing still respiratory acidosis is there. So PaO2 is better now. PaO2 is more than 75. PCO2 is still at the higher side in 50s. Then what you do? So what is the strategy now? So strategy is, you could do 2 things. One is to clear the CO2, we could increase the amplitude, so in steps of 2 to 3 up to 5, or you could decrease the frequency. So frequency in steps of 1 to 2. So and then so look at the PCO2, look at the gases, and depending on that, you could adjust those settings. So now ABG showed a decrease in PaO2. PaO2 has dropped down to below 50. Then what is the strategy now? As I discussed, so you have 2 options. One is to increase the mean airway pressure, and the second one is to increase the FiO2. So what I would do is, I would increase the mean airway pressure fast and look at the oxygenation, oxygen saturations, and then repeat gas. And depending on that, if it required, then I could also increase the FiO2. But initial one is, I would increase the pressures fast. So we repeated gas again. Now the ABG showed metabolic acidosis, and the respiratory acidosis is also there. Then what is the strategy now? For respiratory acidosis, again you could work on the amplitude and you could decrease the frequency further and then see the PCO2. For metabolic acidosis, you could what you need to do is, you need to examine clinically and look at the perfusion, look at the blood pressure, and then see whether the baby is in shock, and then manage the shock accordingly. See if the baby needs any boluses of normal saline to improve the perfusion. Now the ABCs are stable. Then what's your strategy now? So when we start weaning, the training, the thing is, the weaning actually starts from the time of intubation. Our teaching is, if somebody asks when we will start weaning babies, the weaning starts from the time of intubation. So there is no kind of fixed time. There is no kind of hard and fast rules. No, you start weaning at this point of time. It's not like that. Okay, so now ABGs are stable. You wean just oscillation. So initially, what we will do is we'll initially wean the pressures, wean the FiO2 fast, wean down to 30 to 40%, and then start weaning pressures. Pressures, you count down the pressures in steps of 1 to 2, and once you wean down the pressures to 10 to 12. And the FiO2 is around 30 to 40. and the gases are stable, X-ray is okay, and baby's clinically stable, spontaneous respiratory effort is also started, then you could consider changing over to conventional ventilation and then weaning further. Or directly extubate. No, the question here is, can we directly extubate onto CPAP or other non-invasive modes, or can we directly extubate to oxygen? Yes, you could extubate, as long as baby is clinically okay, as long as gases are okay, as long as radiologically the lungs are clearing, then there is good spontaneous effort is there, then why not? You could directly extubate onto non-invasive ventilation or to oxygen. But most of the times, 8 out of 10 times will end up shifting to conventional ventilation and then wean. So quickly about oscillation, I've already discussed about mean airway pressure, what you do, and also frequency. I'm going to skip this slide. And then the oxygenation I've already discussed. It basically depends on mean airway pressure, and if I go to carbon dioxide depends on frequency and amplitude. I'm going to skip this slide quickly. And then let's go to the evidence. We discussed about the clinical scenario, what you do and all. Now go to the evidence. Here in this study, basically they studied in newborns more than 0.5 kilos. It's a good number, 86 in oscillation and 90 in the conventional ventilation group. Basically, what they have shown was the oscillation provides effective ventilation and improves oxygenation. It reduces the risk of air leaks when compared to conventional ventilation. That's what they have found. In this PRO study, so this is also, it's not that big study, but they've done in level 3 centers, 60 in conventional ventilation and 64 in oscillation. So what they found was oxygenation improved more rapidly when the baby was oscillation, and surfactant dosing was less frequent, and more babies survived without chronic lung disease at 30 days when compared to conventional ventilation. Let's go to the UCAS study. It is basically this study, on chronic lung disease of prematurity. They've done in preterm infants. So it's a big number actually, and 400 on oscillation, 397 on conventional ventilation. The outcome, what they found was there is no difference in outcome as far as death or chronic lung disease is concerned. And oscillation versus conventional ventilation in very low birth weight infants. The weight is basically multi-center trial. It's a bigger study. So what they found in that study was the babies who were in oscillation, they've successfully extubated earlier when compared to babies on conventional ventilation, and 56% alive without supplemental oxygen at 36 weeks when compared to conventional ventilation, 47%. Let's go to the clinical scenario. Another clinical scenario is a term male baby for day 1 with a possible meconium aspiration syndrome, and so clinically and so the echo wise showed severe pulmonary arterial hypertension. Baby brought to casualty in gasping state, intubated. Baby was not maintaining saturations on conventional ventilator. So then what you do? So initially we tried on conventional ventilation. Here you could see that it is needing higher pressures, the higher rate, higher pressures on 100% FiO2. ABG showed both respiratory and metabolic acidosis actually. So saturations are still borderline like 85 to 87%. So we put the baby on oscillation. Initially, we was needing higher pressures, mean airway pressure of 22, frequency of 10, and delta P of 40, and 100% FiO2. Then now the saturations were maintained. ABG wise, now it's better, and metabolic acidosis was there, and then baby was also in shock, and we corrected the shock. This baby was an oscillator. And then we improved and we weaned ventilation, and we shifted it to over to conventional ventilation, and then we extubated onto non-invasive ventilation. This is post-extubation after 6 hours X-ray, and then after 12 hours of X-ray, you could see the X-ray. There is complete white out is there. There is massive pulmonary bleed. So what we have done was, again, we kept the baby on oscillation. Here you could see the X-ray while the baby was in oscillation. And then baby got better and weaned ventilation and then extubated. This is the X-ray at the time of extubation, and this was the X-ray at the time of discharge. So let's go to the evidence now. Basically, the efficiency of oscillation combined with the pulmonary surfactant in the treatment of meconium aspiration syndrome. This is a good study actually. They have divided into 3 groups. In the first group, this group is babies who were on conventional ventilation. Second group were on oscillation. Third group were on both on oscillation and also received surfactant. Let's see what this study showed. The ventilation time, duration of oxygen therapy, and hospitalization time of group 2 and 3. That means the babies who were in oscillation and the babies who received surfactant also, the ventilation time and was significantly shorter than compared to other. So early use of oscillation combined with surfactant therapy to treat meconium aspiration syndrome has significant therapeutic benefit. That's what this study showed. Another study, management of meconium aspiration syndrome, that's basically oscillation and compared with conventional ventilation. Here the conclusion from this study was oscillation, they tried as initial mode of ventilation. That's what you found was there's an effective strategy when compared to conventional ventilation. Let's go to the clinical scenario again. This is another baby, term 2.8 kilos, presented with respiratory distress since birth, not maintaining on conventional ventilation. Then, of course, we decided to go on to oscillation. We oscillated. We also given surfactant. And then pH is also there. We treated pH initially. We started the intravenous sildenafil. So these are the X-rays. While the baby given oscillator, then baby got better. We weaned ventilation and then shifted over to conventional ventilation. This is another clinical scenario. It's a term baby 2.7 kilos. Section was done because of non-progression of labor. Respiratory distress was there since birth. There are no other risk factors. Surfactant was given at referral hospital. The baby was referred to us because of the persistent ventilatory requirements, the 24 hours of life. And when the baby arrived to our casualty, baby was in shock and had a pulmonary bleeds as well. That was the X-ray. So we kept the baby on oscillator. Echo showed moderate AST, PDA, and moderate pulmonary arterial hypertension. And then this baby also needed inhaled nitric oxide and also IV sildenafil as well to manage pulmonary arterial hypertension. Got better, weaned ventilation, and then extubated. This was the X-ray at the time of extubation. Another scenario, it's basically preterm 30-weeker, weight is 1.1 kilo. The indication for section was preeclampsia. So you could see the X-ray. This is SDLD, surfactant deficiency lung disease. Initially, we tried CPAP, but so we couldn't. The baby still having a respiratory stenosis, and then ventilated, and then we put the baby in oscillation. We'd given surfactant as well. Got better, and this was the X-ray at the time of discharge. So let's go to the evidence again. This is the meta-analysis of 15 randomized trials to see whether there is any difference in oscillation when compared to CMV as far as pulmonary outcome is concerned. Here they didn't found any significant difference. Another study, oscillation comparing with conventional ventilation in very low birth weight babies. So what they found was, this is a bigger study on 500 newborns. What they found was a small but significant benefit in the pulmonary outcome for very low birth weight babies. So they found some differences there, some significant differences there when the baby was in oscillation. This is another study, oscillation on oscillation. Here, what they found was the oscillation, whether the oscillation is superior to conventional ventilation or not, that the evidence is lacking. But they found better results, especially when there is air leak syndrome. So now when, of course, when there is bronchopleural fistula, they found that oscillation is oscillation works better when compared to conventional ventilation. So this is the Cochrane database systematic review. It's a bigger one. It's 19 studies involving 4,000 plus newborns. So what they found was they didn't find any significant difference in long-term neurodevelopmental outcome, and there is no evidence of effect on mortality. But what they found in this systematic review was there is small reduction in the risk of chronic lung disease when compared to conventional ventilation. So another study, oscillation versus conventional ventilation in P terms without antenatal glucocorticoid prophylaxis. So in that, what they found was the babies who were an oscillator, they reduced need of, in those babies, they found the reduced need of ventilator support, surfactant therapy, and reintubation rates are less, and then shortened so duration of stay when compared to the babies on conventional ventilator. Let's go to another scenario. So it's a term baby 2.4 kilos. This is a baby with transposition of great arteries. This is immediate post-op period. Sorry. Initially, we tried conventional ventilation in post-op, but we couldn't manage. Then we shifted over to oscillation on post-op day 4. And these are the X-rays on day 1, and then you could see that when we put the baby in oscillator, that the X-ray got better on the right-hand side slide. And then these are the X-rays at the time of extubation, and then you could see the X-ray at the time of discharge. So what I'm trying to say is, the oscillation works in babies with the congenital heart disease, especially during post-op period, in babies with the transposition of great arteries, in babies with the total anomalous pulmonary venous connection, in babies with the complex hearts, tetralogy follow, etc. So let's go to evidence again. So oscillation in infants undergoing cardiac surgery. So in that, what they found, whether there is any difference, they didn't find any difference in the mortality as such, but what they found was there is a shorter length of stay when we put the babies on oscillation when compared to conventional ventilation, but there is no difference in mortality. So let's go to the clinical again. Oscillatory adjustments, we've already talked about that. So ventilation wise, carbon dioxide clearance we already discussed, what to manipulate. So mainly the amplitude, one is delta P and the other one is, as we discussed, frequency. So one is could increase the amplitude, other one is to decrease the frequency to clear the CO2. And then the small babies with the surfactant deficiency lung disease, you could manage with increase in frequency, but usually we will keep the frequency around 10 and then work on. So when we decrease the frequency, as I've already showed, that increases the carbon dioxide clearance, unlike in conventional ventilation. So for airleaks, what to do? So in NEMOS, so this is the low volume strategy. Oscillation somehow works. So what we will do is we'll keep the pressures on the lower side. So 1 to 2 centimeters of water below mean airway pressure on CME. So we keep the baby in a relatively higher FiO2 when you have a baby with airleaks. But rescue oscillation, what are the settings? I've already discussed. We will keep the mean airway pressure 2 centimeters of water above the pressures on conventional ventilation. But in airleaks, we'll keep the lower pressures and higher FiO2. But prophylactic oscillation, So we're not going for prophylactic oscillation nowadays. So, we used to do is, like 10, 15 years back. We've been oscillating babies for the past 25 years and 20 years in India. We used to put the babies on prophylactic oscillation as initial mode of ventilation. Now we stopped doing it. Most of the times we'll try conventional ventilation. We're using oscillation as a rescue mode. So initially we'll start with the lower pressures and then work on the pressures. So normal inflation. So once we oscillate the baby, so of course we need to do the X-ray within half an hour and look at the right hemidiaphragm. So look at the inflation. Normal inflation will be like the 8th or 9th rib. So over inflation, if it's more than 10 plus, and you can also sometimes you could see the intercostal bulging of lungs, and then sometimes there is some cardiac air will be there. So under inflation, of course, there will be no high. You could see the diaphragm is on the higher side. So once the baby is stable, so weaning, as I discussed, once the baby is stable, once the FiO2 is down to 30%, then you could cautiously decrease the mean AFib pressures in steps of 1 to 2. Once you wean the pressures to 10 to 12 pressures with normal cases, better X-ray, clinically better, then go back to conventional ventilation. So this is our data in the last 1 year, I think. So now we oscillated most of the babies, with surfactant deficiency lung disease, then meconium aspiration, then congenital pneumonia, then comes other babies, PPHN and cardiac babies. To sum up, the oscillation wise, there is some evidence to say that oscillation is helpful in reducing the risk of chronic lung disease. There is no significant difference in neurodevelopmental outcome. There is insufficient evidence to support the use of elective oscillation compared to conventional ventilation. So when you look at the evidence in the last 20, 25 years or so, there is so many studies are there. There's some studies showing that there is definite benefit is there. But if you take overall and evidence, if you take all systematic reviews, there is a kind of very insufficient evidence to say that oscillation is definitely helpful when compared to the conventional ventilation. But there is some evidence of early use of oscillation, especially in babies with the meconium aspiration syndrome. And there is definitely better pulmonary outcome in those babies, and when you also give surfactant. So we've been oscillating for the past 25 years, as I've said, in the UK and also here in the last 20 years or so in India. Somehow oscillation works, even though there is insufficient evidence for that, but the oscillation definitely works in some babies. So finally, I would like to end my talk with the Japanese proverb: once only staying active will make you want to live 100 years. Like our Dinaka sir is a kind of always proactive person, and very dynamic, and you all be like that. Finally, I would like to end my talk is, this is the COVID-19 season. So be careful, take all precautions, wear PPEs when you're dealing with sick children, when you're in casualty, when you're in intensive care. First, take care of yourself, and then take care of your family, and then take care of society and the country. Thank you. Thank you one and all. Thank you, sir.
Yeah, so it was a wonderful presentation. I request Dr. Seshagiri sir to start the presentation. Sir, you can stop sharing the slide. Rama Rao sir.
Yes, sir. One second.
Stop sharing the slide. Yeah. Seshagiri sir, yeah.
Yeah, I'll stop it.
Yeah. And Seshagiri sir can start sharing the slide. Please start the session, sir.
Sir, is it okay? Can I start?
Yeah, yes, sir. Yes, sir. Please start and speak little louder, sir.
Okay, right. At the outset, again, I would like to thank once again Dr. Prashant, Dr. Dinakar for giving me this opportunity to interact with people. And also I have to congratulate uh, your team, because all webinars I am watching regularly last 2 months, the numbers are dwindling, but your numbers are gradually increasing. I have to congratulate you and for that once again. And sir, as already told, Ramarao and Dr. Satish have told a lot about this HFO. What is the what is the mechanism of HFO working by Dr. Satish the day before. And today, Dr. Ramarao elaborated regarding the HFO in different conditions. And again, I'll not go back to case scenarios, because I want to emphasize again few basic points. Because today, just I want to emphasize on you two things. One thing is uh, just what are the, I mean, it is not HFO, he said somehow it works in some babies. Why it doesn't work in some babies? Maybe if you understand the basic physiology, why it works in some babies, why it doesn't work in some babies, then you'll know why it doesn't work in some babies. That is thing which I want to, if you, and also the same thing will not work in all babies, like recruitment, which is there, will not work for all babies. So you have to individualize your strategy for particular baby. Then only HFO works. It's not like a simple ventilation. It works in few babies terrific, and it's, sometimes you will be in soup if you go to the HFO without basic knowledge. So just I want to try again, go to basics for 5 to 10 minutes, and then I'll go to application of HFO in a non-recruitable lung. Okay. Let us start. Why HFO? Because basically the intubation, basically we are interested in the lung injury. Lung injury starts from the intubation. So what is the importance of ventilation? Because we're trying to avoid ventilation by all means, because we don't want any baby, I mean, for ventilation induced lung injury. So we are trying to avoid ventilation. Basically we are moving towards non-ventilation, that is probably non-invasive CPAP, early CPAP, delivery room CPAP, non-invasive ventilation, even non-invasive HFO, so nasal HFO. So we are moving towards non-invasive ventilation to avoid ventilation-induced lung injury. So in this aspect, there are sometimes you cannot avoid intubation. You need to intubate the baby to save the baby, to further treat the baby. There probably you can take all the evidence which is available with us to protect the baby's lungs. That is called protective ventilatory strategies. And HFO is one of the important lung protective strategies. The outcome data shared by Dr. Rama Rao just now, not very encouraging, but still without probably there is no NICU which is not using HFO. HFO has come into vogue almost 50 years back, but still the outcome data is not matching, because so many things, because our knowledge regarding ventilation, induced lung injuries changing continuously. It is evolving process. Probably you will understand the more and more regarding injury, probably will change our protective. Whatever I am speaking today might not be true after a few years later, or sometime later. So we need to understand what is the present scenario and what is the best we can do to avoid ventilation induced lung injury. So basically the basic funda of lung protective strategies to avoid trauma related to atelectasis, and to avoid trauma related to overdistension, and to avoid excessive oxygen. These three basic funda of lung protective strategies. If you follow these three strategies, probably most of the times you will come out avoiding any basic major lung injury to the lung. So to put it in a graphic manner, probably you need to open up. So you have to give adequate PEEP. There is no expansion, even in non-invasive CPAP or non-invasive ventilation. We have to give adequate PEEP, and at the same time, we have to limit your tidal volume. You have to limit your pressure, so that avoid injury to the lungs. And this is the basis of the lung protective strategy. And if you see, compare conventional ventilation to high frequency ventilation in the, even in electronic microscopy, this is normal inspiration, that is normal expiration. In the normal expiration, you can see the alveoli not getting completely collapsed. Whereas in conventional ventilation, if you see in the expiration, the alveoli are getting collapsed. But if you see the same, the third one in HFOV, the expiration, the alveoli are preserved almost like similar to normal ventilation. So HFO is almost physiologically similar to normal expiration. So maybe you can postulate that the injury, lung injury related to atelectasis or overdistension might be less with the HFO. Probably our more studies will come, more evidence will come in the future. More probably we'll get used to more which disease, what probably, which settings we need to. If we are becoming more and more aware of the things, probably we'll use more HFO in the coming future. So this probably lung recruitment, which is in vogue, probably this is systematic stepwise approach. Here we start with some initial settings, depending on the lung initial conventional settings on the map and the conventional settings. And then you gradually increase, you reach a setting where P max, and then you decrease it to the again closing pressure, and again you'll just maintain the map at the level of the optimum PEEP. This has been explained by Dr. Rama Rao in detail. I will not touch this. Probably 3-4 things you need to remember. This is one thing is opening pressure, closing pressure, and optimum pressure and maximum pressure. So you always stay in the optimum pressure. That is the most important thing. And this is called lung recruitment, which is now probably this works better when there is a homogeneous lung disease like RDS, that is commonest is again HMD, which we ventilate for the babies. Apart from that, this might not work for the other conditions like where the disease is not homogeneous and atelectasis is not major component. Like probably this is the most important side, comes again and again in any ventilation class, where you need to stay in the safe place, safe window, so that you stay safe and the baby is in the safe zone, so that you will not get into either this area, red area, or over distension area, so that maybe it appears, I mean, now even stay home, stay safe, so that it is your home. You should not go away from this safe zone whenever you are ventilating. This was again told by Rama Rao, Dr. Rama Rao Garu. And again, I need to emphasize that probably this is the most important thing. One, you have to remember, this is the zone where you have to work. So one more thing when you are dealing with the HFO, again, Satish already told the day before regarding the various modes of gas transport in the high frequency oscillation. But one point interesting to me, just I want to highlight, because this is the beauty of high frequency ventilation. When you are dealing with the non-homogeneous lung, probably example is meconium aspiration syndrome, where the atelectatic parts, especially atelectatic parts, will receive more pressure, more amplitude compared to the already distended parts, so that there will not be any over distension, and also the pressure reaches where it is required. Probably this will help us in dealing with the non-homogeneous condition. The same baby, if it is put on a conventional ventilation, both these alveoli will they'll get same amount of pressure, so that one will not distended, other will get over distended. That with this mechanism, whatever the mechanics this works, HFO works, probably this is going to help us in managing asymmetrical lung disease, where some areas are collapsed, some areas are distended. So the concept of lung protection is also changing. We're going from higher volumes to lower volumes and low plate pressure, and we're opening up the lung, that is open lung approach, and low driving pressure, and also low transpleural pressure. So many, it is changing, evolving from 2000 to 2020. So many approaches. Probably we have to make use of all the approaches whenever you are ventilating a baby. A difficult case, basically a simple case will not go for HFO because it is not cost effective, and also it's not required. So whenever you are dealing with a difficult case, you have to see which baby, I mean, what is the size of the baby, what is the pathology, what is the um, uh, frequency, amplitude, and thing you have to use. So it is individualized to each baby. Because I am not telling the numbers, because numbers doesn't matter, because if you understand the basic pathology of that particular baby, probably you can, if you know the basics, you can ventilate. So this is a very important slide in the whenever you are dealing with PPHN. The FRC, the lung volume, the pulmonary vascular resistance is at lowest. So either it is low, this pulmonary vascular resistance is going to increase, and if this lung volume increases also, the PVR is going to increase. So you have to work at this. This is the safe zone, the safe window, the safe home, which I told earlier in the slide. Especially it is true in the whenever there is a pulmonary vascular resistance or PPHN case, when you're dealing with, you have to be very careful. If the lung volume is low, your PVR is going to increase because the alveoli is going to collapse, and if lung volume is increased, your alveoli is going to be stretched and PVR going to increase. Either it is true for extra-alveolar vessels, and also true for intra-alveolar vessels. So this is the most important slide. Whenever you are dealing with the in case of PPHN, you have to remember that either increase of volume, either decrease of volume, your PVR is going to worsen and make things worse for you. And your whatever make changes, it will not, unless you have this in your mind, it is not going to help you. So you have to remember that just opening of the lung doesn't help in all cases. Especially it is true for HMD cases, RDS HMD cases, in some cases, pneumonia or simple cases. But in some cases, if you are going on, if you are overzealous, if you are going for more PEEP or more MAP, then probably results in over distension and resultant edema formation. And because of over distension, there is poor lymphatic drainage, and that complicates, and also impairment of RV function because of decreased diastolic filling of the heart. And ultimately, all these things will have impact on the systemic hemodynamics. Whatever effects, positive effects you want to have, you will end up in having systemic negative effects. So you have to keep always, you have to work in that safe zone of MAP, so that you should not be overzealous, especially where it is you are working with non-recruitable lung. So probably now the recent thinking is atelectatic lungs exhibit a reduced lung whenever you expand over distend the atelectatic lungs, probably more inflammation is produced at atelectatic lungs, and more injury will be produced. So you have to be more careful when you are dealing with some sort of pneumonia and other ARDS cases. It is not true for RDS, but other cases this statement holds good. So the basic approach is open the lungs and keep it open. So this is the modern OG for the treatment HFO or any other ventilation strategy. But does this hold true for all the diseases? Yes or no? If the single answer, probably it is no. So it works in most of the neonatal conditions, but not all. So what are the, probably it is important as a as a neonatologist are dealing with, because you are not dealing with all RDS cases. Now you will get very different type of cases where you have got different diagnoses, different pathologies. So you can't apply the same opening of the lungs to the maximum 20-25 maps and coming down and recruitment, de-recruitment, optimum PEEP. So it doesn't work for all the babies. So what is important is you have to know where you cannot use this high lung volume strategy. Unless you are thorough with your knowledge, probably you end up using your recruitment strategy in the wrong baby, and we will be doing more harm to that baby. Okay, so where it is required, definitely it is you have to do, and that will be useful. But you have to know that in some conditions where congenital diaphragmatic hernia, PPHN, pulmonary hypoplasia, air leaks, and PIE, these lung recruitment manuals might not be, they will not help you. And also sometimes if you do overdo them, you will end up in more trouble and your baby will worsen. So you have to understand the disease pathology, physiology, and individualize your strategy of HFO in that particular. Because HFO is very simple, as sir was telling, even Rama Rao, there is only amplitude which you have to change, and the second thing is frequency. So that those two things only you need to change. So it is not a great job actually. But if you apply the wrong PEEP and the wrong frequency to the wrong to the baby, probably you will not get the correct desired effect. So even if you go to the basic ventilatory strategies of HFO, it is one thing is optimizing lung volume, that is in RDS, where atelectasis is a major issue. And second strategy is it is limiting pressure exposure, probably all other things like air leak, CDH, and most other situations. So your recruitment will work mostly in RDS, but you are limiting pressure and taking care of all other things probably is more important in other things. Let us go to a very simple case which we last month we managed. This is a 1-day-old baby, late preterm, 35 weeks, low birth weight, normal vaginal delivery, no asphyxia, was referred to our center in view of respiratory distress since birth, and it is already diagnosed case of CDH. There is a history of antenatal scan, but there is no details. There are no details about which details like lung head ratio or other things, which we are interested to know the prognosis. The baby was otherwise stable, but not maintaining the saturation. So we have to intubate the baby, and we have intubated. This is the X-ray of the baby. This is on 12th March. Okay, last March. So in this COVID times. So here, there are two questions again. One, whether we should go for HFO, whether we should go for conventional ventilation, because we are master. If you are a master of HFO, should I go? So what is the evidence says? What is the? It comes under. I told you it comes under non-recruitable lung, because it's not pathology is completely different here. So what should be our approach? So just to recapture the CDH, some important points. It is not very common. Left side is more common. Male sex is more affected. Sometimes it is associated with chromosomal anomalies, and pulmonary hypoplasia and hypertension are part of it. And if you know this probably, and it is very important, one thing for in the management. Second thing is we need to counsel the parents, because once you are taking over the surgery, and we need to give full information and prognosis to the parents. If you give correct prognosis, that will help you not to avoid other medical legal issues or any other. So that we need to have some information regarding the baby before surgery to give any information to the parents. So this is basically pathology where the pulmonary lung hypoplasia is part and parcel. So it is not only ipsilateral lung which is hypoplastic, and the other lung is also, the other side lung also hypoplastic. That is the most important thing you need to remember. And coming to predict, this is the lung, probably this is just put the lung of CDH. If you see this, probably how much you ventilate, how much you do whatever do. If the lung is so small on the right side, so left side, and probably you know that what you are dealing with. So when you are doing manipulations, or when you are talking to the parents, you know that what you are dealing with and what is the prognosis. Because whatever you do, almost 30% cases will not improve, because severe lung hypoplasia or severe pulmonary hypertension will be there. So this is apart from that hypoplasia, the lung vasculature also is going to give a lot of problem during ventilation, because these things are associated with pulmonary vascular resistance, increased pulmonary vascular resistance. So apart from that, this is also associated with ventricular dysfunction, because right and left ventricular hypoplasia will be there, so that you will have problems during ventilation. Apart from ventilation, the other things also you need to have. So this probably predictors which if you have with you, you can discuss the prognosis. Lung head ratio is very important. You should know how this is calculated on the contralateral lung, not in the ipsilateral lung. Contralateral lung head ratio, if it is more, probably the prognosis is more. If it is less, the prognosis is less. Apart from lung head ratio, the other thing which is more important is liver herniation. If it is there, the prognosis is not good. If it is not there, probably the prognosis is good. Probably if you have this information with you, probably you can plan your ventilation or your treatment, and also you can discuss the prognosis, correct prognosis to the with the parents, so that you are sure what you are dealing with. And if your lung head ratio is good, and you can probably you can give them more than 90% survival if your liver is normal. So this helps in managing not only your planning, not only your management, but also giving good correct prognosis. So this is apart from ventilation. What are all the things important you should not forget whenever you're managing? Coming to ventilation, probably initially the question is whether to put on all the babies on conventional ventilation or high frequency ventilation. So the answer is maybe you should go to again some studies, where some retrospective studies they show that the early use of HFO has improved the survival rate in retrospective studies. Many retrospective studies, I just quoted one or two retrospective studies where the congenital diaphragmatic hernia ventilation early HFO has had good outcomes. But to answer this question in a correct way, probably one good randomized control trial was planned. This is conventional mechanical ventilation versus high frequency ventilation for congenital diaphragmatic hernia. Very big trial of more than almost 200 babies. This is called VC trial in 2015 published. Almost, if you see this trial, total number of patients are 171. Coming to HFO arm, the patient survival is 68%, whereas in CME it is almost 76%. And coming to BPD, this incidence is HFO is around 32%. There is the conventional ventilation, the BPD incidence is 30%. So there is no much difference in the outcomes. So probably, and other thing is to continue this, even the switch, whenever you are planning study, if it is not working, probably switch. If you take the switch also in conventional ventilation, the switch ratio is almost to HFO is 6.6%, whereas the switch ratio is almost 23%. In center where ECMO facilities available, almost the same where facilities are not available also. So even if switch is also less in a CME cases to HFO compared to HFO cases back to CME ventilation. So the outcome of this trials shows that there's no difference in the mortality or BPD compared to conventional ventilation or HFO, whether you start this or that first. And also there is less treatment failures in CMV, and there is shorter duration of ventilation in CMV group. And the CMV group, the babies are less likely to receive inotropic support or sildenafil or ECMO. So this means that there is no advantage putting the babies initially on high frequency oscillation. So the best thing is probably you can use it as whenever your mechanical conventional ventilation is not working, rescue HFO you can use. Maybe that is the bottom line of all these trials. And coming to predictors, probably our own trial in India, in AIMS, the most important predictor of this CDH is again PPHN. So PPHN is also one of the non-recruitable lung pathology, probably. So HFO again is important aspect of the treatment. Apart from HFO, INO has come here. INO role will come into the effect this area, where probably tomorrow again one more class is there regarding INO. I'll not venture into it now. So regarding PPHN, again few points about PPHN, not because this is not topic of today. Ventilatory support in PPHN again is very important. So apart from ventilatory support, So this is again one of the most important things whenever you are dealing with CDH or meconium aspiration. Most of the times, because of PPHN, you will get into trouble, and this associated with high incidence of morbidity and mortality. So this is again some of the definitions and pathophysiology of PPHN. So different causes are there, where because when you are managing, why, if you know the pathology, probably if it is RDS, you will give surfactant. If it is hypoplasia, probably you will opt for HFO. So each pathology, probably if it is black lung, probably your HFO might not work. So the identifying the pathology will help you to plan the required treatment. So apart from that, there is basically the underlying PPHN is going to give you a lot of trouble. And which one is going to respond? The maladaptation regarding PPHN, which pathophysiology PPHN, maladaptation, usually asphyxia, MAS, RDS, pneumonia. These things easily will respond to your treatment and also INO. But when it is maldevelopment is there, probably this group is very difficult to treat. And where underdevelopment is there, probably they will respond less, but they do respond. Coming to pathogenesis, this I think next class is there for you. I know class is there. And diagnosis, clinically you can make a suspicion, and you can make a clinical diagnosis by simple measures. And echo is the most important thing. Not only in the diagnosis, but also it gives other things like left ventricular and right ventricular function that will help you in the management. So this echo is not only the diagnosis, but also associated, I said it is right ventricle, sometimes dysplasia, some dysfunction will be there, that will help you in the management. So this is a routine flow chart, which all of you are aware. This is again, depending on the blood pressure, how to manage. Maybe you are all aware. And coming to our part, this is ventilation. Whenever there is conventional ventilation is you start with conventional ventilation, taking care of all other things. Once conventional ventilation fails, probably you can go for HFO. HFO settings, again, you need to start with the just same settings of the same map in the conventional ventilation, or just above 1 or 2 above the map in the conventional ventilation. The amplitude of 30 to 40 IE ratio, this you should not disturb, it is fixed. And most of the times you need not touch this in IE ratio, and usually 10 heads. The heads is one important, probably one important point regarding frequencies. The baby is small, the frequency will be more. If the baby is big, the frequency will be less. The need in the frequency will, if the baby's lungs are hard, like RDS, the frequency required will be more. And if the baby's resistance is more like meconium aspiration syndrome, the required frequencies will be less. This is the basic thing about frequency. So coming to randomized trials again, regarding the high frequency ventilation PPHN, this is the landmark study. That's good old study. The same results are being again repeated in many later studies also. Almost this is more than 20 years old study, but the results are same compared to even this latest RCT. Almost similar results are there. So in this, you can see the recruitment or HFO. HFO better works, especially recruitment is better works. This is HFO. This better works when there is atelectasis is there. So in other things like CDH, MAS, there is less responders are there. So you need to, the best is again HFO and PPHN is there. There is the best results seen with combining HFO with INO. There's no doubt about this. But if you just isolate HFO in different lung conditions, this is the HFO, and you see the responders. This percentage of responders is where there is lung pathology, where the atelectasis is more, probably you'll get big chunk of responders will be there. So to bottom line, regarding the PPHN cases, the parenchymal lung disease is there with PPHN. The high frequency ventilation works. And for the pulmonary hypoplasia, again, high frequency works as over distension in the conventional ventilation versus the PPHN. For idiopathic PPHN, conventional ventilation is preferred, and probably no major advantage with HFO. So most infants with PPHN, you have to be moderate pressures and you have to optimize lung volumes. And you need to remember that your pressures, pulmonary pressures are the lowest at your FRC, so that you should not increase unnecessarily the MAP. So that is bottom line about the ventilation in PPHN. And sometimes, as I said, pulmonary hypoplasia also one of the important causes of non-recruitable lungs. So here you see even hypoplasia is seen in CDH cases, and also some oligohydramnias where mild hypoplasia is there. They require some time oxygen for few days, few weeks, and then they'll become normal. And severe oligohydramnias, probably severe hypoplasia. These hypoplastic lungs are small, but they are biochemically mature. Structurally, immaturity will be there, but the problem is they are really highly susceptible to barotrauma. And these cases, when you ventilate, you have to change to high frequency at the earliest. Do not persist with the CMV. So you need to use low pressure strategy, low frequency, wait for the effect, gentle recruitment. Probably these things will help in cases of pulmonary hypoplasia. And air leaks, again the same funda. Again, if it is you need to maintain the moderate pressures, and you need to have lower frequencies, and you have to use accelerator with active aspiration. These things will help you to heal the lesion. Then probably you can again recruit more areas to re-expand. And again, settings I'll not comment because they will vary with the baby and baby, and you need to accept little bit hypercarbia, and also you have to accept whenever air leaks are there, little high FiO2. These things you have to keep in mind. So this is a nutshell about the management of because I have not told about numbers, because numbers vary from baby to baby. So you have to individualize for each baby. The numbers are important because there are only two numbers. One is MAP, second thing is frequency. That you have to individualize. Whatever your changes made, you need to observe. You need to take X-ray. You need to see their ABGs, whether it is showing improvement. Probably you can recruit more. If it is not, then you have to stop and see what is happening to the baby. So this is the rough practical tips which are there. Probably the more the size of the baby is less, probably the frequency is more. And if the baby size is more, probably the frequencies requirement is less. This is the rough guideline. Probably again varies from baby to baby. So index case, probably we this baby did not require any HFO, and we ventilated, and on third day it got stabilized. Now we are doing all CHD cases, thoracoscopic repair, and this baby. But during this post-operative period, because the stomach contents were pushed in, the thoracic contents were pushed in, the baby needed some higher pressure, so we shifted to HFO for a brief period, for a day or two, then extubated. And again on extubation also, baby needed nasal HFO for 2-3 days, and then shifted to CPAP, and gradually baby improved. And I have just quoted a simple case because if HFO is available, it is not that you need to use HFO. But in this case, HFO has helped us in the post-operative period. The abdomen was tight; it was not responding. So post-operatively, we used moderate pressures, then the baby improved. And even during extubation also, baby was not maintaining on nasal IMV, so we have changed to nasal HFO for 3-4 days, and gradually baby weaned off oxygen and discharged on day 15. And in spite of the baby 1.8 kilos, and the baby, this is a good aspect in this baby is we did CDH repair by thoracoscopic or laparoscopic repair, which regularly we are doing now. Open approach, unless it is initially all babies being tried on thoracoscopic. If it is not, then only it is being converted into open approach. So to summarize, just avoid recruitment maneuvers whenever they are not required or not working. you have to see that what is the disease degree of parenchymal disease, and it decides whether recruitment works or not. And also you have to see like pulmonary hypoplasia, whether it is susceptible to barotrauma, and you have to see that what is the state of the pulmonary vasculature. These three things are important whenever you are doing recruitment. And if your recruitment is not working, you please do not continue, and see what is happening and identify the cause for not working. And your strategy should be individualized. A low pressure strategy with time dependent recruitment can be very effective if aggressive recruitment is contraindicated. So this is bottom line. So the bottom line again is individualize each baby. Not all babies will improve with recruitment. So I think this is my message. And maybe all stay home, stay safe. Thank you for all the members, 120 members who stayed until the last minute. Thank you. Thank you, Prashant.
Hello.
Prashant, please.
Over to you, sir. You can start the discussion, sir.
Yeah, Prashant. I received the questions from Facebook. What about the people they are typing and sending? Where to see? I don't know.
Sir, you can check your chat box. It is all come to your chat box, sir. Chat.
Where is
Please.
the chat box?
You see in the phone, sir. You have more. Click on the more.
There is no more. No more.
Join audio, start video, share content, participants, and more.
Yes, participants is there. More, yes.
Yeah, you click on more, you will see chat. First one is chat.
Yes. Okay,
Click
now
on,
I have seen.
Yes, sir. Click on
Yes,
the chat.
yes. I got some questions. So both the batsmen are ready, please, sir. Please, sir, please. What is the maximum approximate MAP acceptable in preterms on HFOV? At what level can it be increased? So, Dr. P V RAMA RAO, sir. RAMA RAO garu. Hello.
Can you hear me? Hello, can you hear me?
Yes.
Okay, sir. There's no kind of cutoff for the median pressure. So you just increase the pressures like 20 or up to 25. So it's not like that. Basically, you need to see what kind of pressure baby tolerates. And also you need to look at the underlying lung pathology. They could tolerate higher pressures as well, but it's basically depends on the underlying lung pathology. So, for example, in STLD, so as I said, that initial the starting ventilator settings is the pressures is the same. But you work on slowly and see the recruitment. So look at the oxygenation, and depending on that, you increase the pressures in steps of 1, 2. You could might as well go above 20, and you could go up to 25. There is no kind of an actual cutoff for that. I would say the answer to your question is it's depends on the underlying clinical condition and pathology, and then what kind of problem you are dealing, and increase slowly in steps of 1, 2, and increase the pressures and see. But I don't think any book and anywhere any
yes, sir. Yes, sir.
There's no number as
yeah, I think so. Very clear message from actually Seshagiri and both speakers. There is no numbers actually. Preterm, this is the number, this is the number. Actually, both the speakers have told very clearly, see the disease and decide.
Yes.
Number 1. Number 2, once again for P V RAMA RAO. Sir, what is your experience with monitoring DCO2 on HFOV from Abhijit Singhal?
Sorry, say it again.
What is the experience of DCO2?
Here, no, we are not doing on that and regularly. So I think my experience, I'm not looking at that DCO2. I don't know about Dr. Sheshagiri. So would you like to?
Yes, sir. Because DCO2 is always displaced in 6000. We are using regularly, and basically when maybe tomorrow I think Manoj will tell about it more. But still, the question is there. We'll try to answer because DCO2, if it is improving, probably it is the tidal volume frequency into tidal volume square. That is DCO2 is if you started with some DCO2 and day one. If it is increasing, probably there is diffusion coefficient of the carbon dioxide. If it is improving, means probably you are improving, and also you have to look simultaneously at the compliance and resistance which are displayed simultaneously. And also in the very small babies it is very difficult, but if in bigger babies probably it will help. And also depending on the initial DCO2 in the volume guarantee ventilation, definitely you can fix that for that particular baby so that your amplitude automatically comes down, so that it automatically weans down. That also will help you to in the volume guarantee basically. But you are looking at without volume guarantee, and looking at that value definitely helps. Yes.
Sir, can I add both speakers? Can I add some more things, please?
Yes, sir.
Yeah. Sir, DCO2 before volume guarantee, that is the main thing what we used to follow, because DCO2 means frequency. Example 10 frequency we kept. The volume what it is giving only machine will display from the anemometer, means sensor. If it comes around 2 ml per kg, example 2 kilo baby, you ventilated for some disease, frequency you kept 10. Delta P, that is amplitude, you kept something. Machine is telling us it is delivering around 2 ml per kg. Example 4 ml it is delivered. 4 into 4 is 16. 16 into 10, 160 is DCO2. With that DCO2, we used to tell our PGs, write down the DCO2, what is that level, what is the PO2, PaO2, what is the PaCO2 in the VBG or ABG, whatever we used to do, write down. And we used to take the chest X-ray. So that means we used to decide this is the optimal volume this baby needs by DCO2. If the DCO2 is started coming down, then immediately what we used to tell is probably DCO2 is coming down, means volume is going to the baby very less. That means ETT is obstructed, or lung is become either resistive or decreased in compliance or more secretions. That is the way we used to decide with the DCO2. Because previously, now also DCO2 plays a major role without volume guarantee. So suppose if the DCO2 started increasing, that means as Dr. Sheshagiri told, lung is started improving. So volume is started increasing. So that is the time we have to reduce our delta P. It is like a conventional ventilator. So like in conventional ventilator, how volume is more popular, like that in Hfov also volume has come up. Tomorrow class, I think so, we will tell after the volume guarantee, the DCO2 value is slightly reduced. Without volume guarantee, example who are using SLE 5000 or Fabiana machine, or any Leone machine without, or any other machines without volume guarantee. Even Fabiana is having volume guarantee. I am telling previous. So DCO2 is very important, sir. Okay, sir, one more question we will go. This is from any predictors on CT in the post-delivery newborn with CDH to predict prognosis for surgical successes. Regard from Karambir Gill from Ludhiana. This is for Dr. Sheshagiri. CT scan prognosis after the delivery, CDH.
CT scan, usually CT scan, probably if you have ultrasound, as I was telling in the lecture, if ultrasound report was available, proper ultrasound with lung head ratio, we don't require any CT scan. Usually we don't do CT scan for the babies, and the babies are already on a ventilator, especially on the higher settings and conventional ventilation, or in the HFO, and it is not possible for the baby to take a CT scan. Usually we don't do that, and we depend on the baby's requirement is one thing, and the improvement, probably the echo findings, pulmonary, because the main predictor is again pulmonary hypertension. So if it is less, your requirements are less, probably you can predict. Probably you need not go to until the extent of CT scan. Uh, Probably you can add, Dr. Dinakar.
Yeah,
Yeah.
Dr. Dinakar sir, just to add on to this,
Yes, sir. Yes, sir.
as Dr. Sheshagiri said, we don't normally do CT scans in a baby with a diaphragmatic hernia. So one is it's not required. Second is it's an exposure to radiation. But selectively, for example, in post-op babies and diaphragmatic hernia, still babies not improving. Oxygenation-wise and otherwise, and we know that there is a degree of hypoplasia. Maybe to know the degree of hypoplasia, sometimes to prognosticate, maybe we'll consider in selective cases in post-op period, but not regularly.
Yeah, sir, I think so. CT scan, even I don't know. Why to do CT scan, I don't know. Because in congenital diaphragmatic hernia, we know that associated cardiac problems will be there, or congenital malformation will be there. As like Dr. Sheshagiri told, antenatal scannings will tell us whether what is the fetal, after the delivery prognosis and liver herniation. Sir, even CT scan after that, Karambir Gill, I don't know. How to decide we are ventilating in a safe zone, P V RAMA RAO, sir. How to decide we are ventilating in a safe zone?
Ventilating in a safe zone. It's not just one. So one is you need to look at one is a radiological thing and clinical, and then investigations backup. So once you are oxygenating well, number one. Number two is X-ray wise. X-ray wise, getting better. Number two.
Hello.
Then X-ray wise, so there is no kind of air leaks. And clinically, oxygenation wise improving. We're able to wean ventilation, oscillation. Then we are on the right track. So what I would do is clinical, radiological, and investigative backup. I think that all those three matters, and depending on that, we could say that whether we are in safe zone or not.
Yeah.
Anything else?
Dr. Sheshagiri, add one more word.
Probably again, if we are doing if you take a case of HMD or RDS, when probably before surfactant it is different, again after surfactant it is different, so they have to be careful. So it is not same for all diseases. Again, that bottom line holds good. And whenever they are recruitment also, when they are doing, when they are not sure of what they are doing, it should be very gradual. Once they are in the next stage, if there is some improvement, again radiological or clinical or ABG wise, probably they are in the safe zone. And if the baby is stable, doing fine, and also they are in safe zone, and they can look at the volume curves, and also they can look at the other parameters of the baby, and compliance, resistance, And so many, you have to look at overall, because it's no single factor will tell you that you're in safe zone.
Yeah. Sir, one short key notice for that. What Dr. Rama Rao told and what Seshagiri told, both are the correct answers. Not single factor will tell you your safe zone. Sir, in your machine C20.
Yeah, that is one more. Yes.
C20, this thing will come. See that if it is over distended or under distended. Less than 0.8 is coming, it is more dangerous, sir.
Yes, yes.
When you are going for open lung concept, that means high lung volume status. Distending, then coming down. If you are going, see that, sir. And one more thing. SpO2 RT, you would be definitely in India, since TCO2 is expensive, and we don't keep on doing the VBGs. So we do depend on SpO2. When you are completely, you see that you have gone up to 20 MAP or 18 MAP, then go up. Once the SpO2 started coming down, as Dr. P V RAMA RAO told, coming down SpO2, because TCO2 is very expensive, sir. It is 11 lakhs, they tell 18 lakhs. If newer generation TCO2 is 11 lakhs, if you will so much bargain, you will get it for 9 lakhs. Previous one was 4.5 lakhs, but it used to burn the skin. So, that means oftenly we used to try that and see. But only one thing, SpO2 is better, sir. You once for that optimal, you have to work, sir. For some time with the HFOV, then you will decide. Sir, what is the effect of sigh breaths on HFOV in lung recruitment? It is for Dr. Seshagiri.
Definitely it helps, sir. Again, depends on your pathology. If you are dealing with the RDS, simple RDS, definitely Cypress, whenever you are done recruitment, it helps to recruit the more lung, and again you can calm down on the pressures. So it definitely helps. Again, it depends on your basic lung pathology. If you want to do it the same in the pulmonary hypoplasia where you are ventilating already, probably it will not help. So where there is possibility of recruitment is there, like HMD, definitely you can, definitely it has a role.
I think so, Dr. Abhijit Singhal, you understood? Sigh breaths only if homogeneous lung disease like severe pneumonia everywhere. Sigh breaths we do use. Otherwise, 99% we don't use sigh breaths in HFOV. Only in homogeneous lung disease. Sir, it is from Dr. Murali Rajan from Kerala. What is the indication of HFOV in post-cardiac surgery patient P V RAMA RAO, sir?
Okay, in post-cardiac surgery, there is no kind of absolute indication that what we normally do in our cardiac surgical unit. We have a big pediatric cardiac surgical unit. We do these surgeries regularly. So initially, once a baby comes from the operation theater, we'll of course we'll keep the babies on the ventilator, and then we will say, so if the oxygenation is not good, if the carbon dioxide clearance is not good on conventional ventilation, even with the higher pressures and FiO2, and then we'll look at the gases, and of course we'll look at the X-ray, and then we'll decide on oscillation. There is nothing different when compared to other conditions, other respiratory conditions where we will put the babies on oscillation. There is nothing different. Again, we'll say clinically and blood gases, radiological, and then decide whether that baby needs oscillation or not. So the answer to your question is there is nothing different. We'll say clinically and then decide, so depending on the blood gases, X-rays, and clinical condition.
Yeah, I think so. Correct answer, sir. Thank you, Dr. Murali Rajan. He's from Kerala, my good friend, president of Kerala NNF. My good friend, very nice, sir. Thank you. Sir, Marthandappa from Karnataka. I think so. Just now we answered his question. We cannot do ABGs repeatedly. Can we rely on SpO2? I told you the answer just now, Marthandappa. We'll go because there are a lot of questions are there. We use FiO2 50% as cutoff for surfactant used in MAS. What's your take on FiO2 cutoff value? I don't know what is this question. Both to you speakers.
So I think the question is not clear, but he is asking about FiO2. Maybe when do you want the pressures need to wean off from the high frequency or MAP? Probably is it the question?
Sir, we will ask. We will do like this. Marthandappa, you can raise the hands. After the questions, we will please. You can ask directly. Marthandappa, sir, can we take from Facebook? What is it? Facebook, please. Because there are 110 people were there in the Facebook. I asked around 12 questions. Can I ask you people, please, if you don't mind? Speakers?
Yes.
Yes, sir. Please go on.
I think so. This is for Dr. P V RAMA RAO. Sir, preterm and term baby, can we wean directly from Hfov? If yes, what is the parameters?
Oh, okay. Why not? No, I've already discussed. When I was talking. So definitely, we could directly, wean and then extubate onto non-invasive ventilation or onto oxygen. For that, these are the things to say. One is once we wean the oscillatory pressures to 10 to 12, I would say. Once the baby is maintaining saturations and normal blood gases with around 30 to 40% of FiO2, and clinically and radiologically, baby is okay with good spontaneous respiratory effort, then why not? Definitely, we could extubate onto non-invasive ventilation or onto oxygen. But most of the times, I'm talking about the practical things, most of the times what we do is once we wean the pressures to 10 to 12, FiO2 is around 30-40%, we'll shift over to conventional ventilation and then wean and then extubate. That's what normally happens. But the answer to your question is definitely we could directly extubate onto oxygen or non-invasive ventilation if clinical condition permits.
Yeah, sir, can I add one word, sir? Please.
Sure, Andy.
Sir, preterm baby, Shaila. Preterm baby and term baby. Preterm baby, you can wean directly from Hfov. There is no problem. And put it on low flow oxygen or high flow oxygen or non-invasive Hfov or any non-invasive modes, whichever you are comfortable. But usually when in the preterm baby, I don't want to tell once again numbers, but it is there. Because if you come to that numbers, you are fit, provided CBC is normal, no sepsis, hemodynamically stable. Number one, delta P is 10 to 15 if it is a preterm baby. Delta P means amplitude. Frequency is usually 10 because we are not going to touch any time if it is necessary only. So FiO2 as usual less than 0.3%, that is 30%. So delta P map, usually if it is 8 or 6, definitely we do wean for a preterm baby. For term baby, just add 2 more. That is enough. So frequency 10 same. Delta P instead of 10 to 15, go to 20. Then the FiO2 same 0.3%. Previously we used to read up to 40%. Now they have made it for 30%. That's it, sir. Okay, then once again for the question, it is exactly what is high lung volume concept? Is it open lung concept? Both are same. What do you mean by that, sir? What do you mean by that, and what is the success of that?
Again, I think
Dr. P V RAMA RAO. Or anybody.
Dr. Sheshagiri, you could answer.
Sir,
Yeah,
I think, it is open lung concept, high lung volume strategy are both the same. And basically, whenever again this is pathology where you are dealing with the atelectatic lung, probably ARDS, basically in adults or pediatric population, where you have to open up the lung. So that is high volume lung strategy. And what is the second aspect of the question?
So what you mean by that, sir? Any criteria is there? They are asking, sir.
Any criteria that? So probably when you are failing, one thing is diagnosis. If you are dealing with the pediatric population, if you take putting aside RDS for some time, so definitely you need higher, even in conventional ventilation. If you take the pediatric population, we'll be going the PEEP to the higher levels. So we have to open up the lungs, open up the collapsed alveoli, including. So that is because you are increasing the PEEP to the maximum extent to open the maximum. Even the CT scan evidence is there. You can go up to around 20, 25. So you are opening the alveoli by increasing the MAP or PEEP to the maximum extent. That is open lung concept. So it might not work in some neonatal conditions, as I pointed out, like your CDH, hypoplastic lung is there and PPH is there. So it might not work, but definitely it has to be. It will work in where there is a atelectatic component, is homogeneous lung disease, like RDS basically, and also ARDS in pediatric population.
Yeah, I think so. So it is from your own state, your own Hyderabad only case has come. I mean, the question has come from Nice Hospital. So the same thing. I think so, doctor. I think so. She knows. Sir, Madam Ji, exactly what is HL high lung volume concept? I think so. Both speakers have told criteria. It is simple. There are three things you should achieve to tell you made it high lung or high lung volume concept or open lung concept. Number one is the mean should not go more than 25. Number one, before that you should achieve a good thing. If it is necessary, you can go more, but you should achieve in that limit only, less than 25. Number two, FiO2 should come down to less than 0.4%. Should come down to 0.4% when you are achieving the critical close, just above the critical closing pressure. That is when you reach the optimal pressure. So two things, FiO2 and PaWO. The third thing, SpO2 should maintain more than 90%. PCO2 should be in the normal range. That is the open lung concept. So FiO2 should come down to the things. Sir, one more thing. Sometimes after, this is also from your own state, Telangana, sometimes after high lung volume concept, suddenly baby's SpO2 drops, heart rate either increases, decreases. When I reach sometimes the pressure when I want to do the open lung concept. So needs, once again, whole drama will be there in the NICU, like X-ray, VBG, ABG, shouting at sister, do the suction, baby will succumb. Sir, what should I do? Once I reach some pressure, SpO2 is coming down. What should I do, sir? So anybody can answer, sir. Dr. PV?
So, once you reach the pressures, so let's say that you reach the pressure of 25, and then till that time, saturations for maintaining, and suddenly saturations dropped and the heart rate fluctuations are there. Child went into brady. So I think in that case, you need to suspect pneumo is the first possibility. And then look at clinically, auscultate, and if you have light, put the light and see, and then get an immediate X-ray. If there is pneumothorax, obviously you need to put the chest and in then and there itself. So that's the one thing, and it's you look at the other underlying problem, whether you have induced any problem like air leaks. That's what I would look for.
Yeah, sir. After listening to your question, sir, there is no pneumothorax. What should I do? He has asked once again.
Okay, so there is no pneumothorax, and Again, so heart rate is fluctuating, is dropping saturations, other underlying things like whether the baby is in shock, whether there is any metabolic acidosis, how is the perfusion, and how is the blood pressure. All those things does matter, isn't it? Why there is a sudden drop in saturations and body. So I think I would concentrate on those things first. If there is shock, I'll correct it, and then reassess again. I know if the baby still be like that, I would look for other ventilation strategies.
Yes, sir.
Maybe other thing you look after is probably tube block, tube displacement, or ventilator malfunction, and all those things you need to look at.
So I think so, Dr. Suman, you understood? Suman Reddy. Okay, you understood what sir has told? ETT displacement, ETT block, okay, take care. And pneumothorax also take care, and shock. I'll add one more just word. In case if a heart rate is increasing but SpO2 is dropping or baby looking pale, please push the volume, because sometimes your map might have increased. So patient might have need IVC, SVC, blood was not flowing. So preload might have decreased for the either RV or LV2. So you push the volume. If it needs inotropes, please take care. Decrease the MAP. That could be the reason, Sumana Reddy. Okay, sir, how to set the frequency? Anybody, how to set the frequency? Oh, see, 1 second, sorry, because there is a same question is there from Jammu Kashmir also. How to set the, you people can tell at a time. How to set the frequency? That is all one question. Another question, how to set the frequency in what is it, PIE? Because I read some books, some journals are telling increase the frequency, some journals are telling decrease the frequency. Just now, speaker told decrease the frequency. What to follow? First speaker, please, P V RAMA RAO, sir.
Okay, sir. No, one is frequency. How to set the frequency? There is again, I'm not going to tell about the numbers, but usually in newborns we'll start the frequency with 10, and we'll work on depending on the CO2, we'll work on whether to increase the frequency or decrease the frequency. For example, if the PCO2 is really high, then we could decrease the frequency. It could go up to would come down onto 5, and at the same time, so if there is a decrease in PCO2, the baby is hyperventilating, then you could increase the frequency. It could go up to 15, but usually normal initial setting frequency would be like around 10. That's what I would normally do. So with regards to the pulmonary interstitial emphysema, because of this tidal volume, this thing, maybe you could start with the lower frequencies. Lower frequencies first, and then work on depending on the radiological things and the blood gases, and then clinical one, and then decide about maybe in that particular condition you start with lower frequencies. Dr. Seshagiri, anything to add on?
Sir, frequencies basically it is very simple. So basically, if it is you're dealing with the compliance of the lung is low, probably they need. If the baby size, compliance is low, baby size is less, probably this baby needs more frequencies, maybe 12 or up to 15. If the baby size is more and the resistance is more, probably those babies need less frequencies. Again, as Rama Rao sir told, the carbon dioxide, if it is more, probably you have to come down on the frequency. The other thing, the second part of questions he was asking, in PAE, what is the optimal
it is
frequency?
for you only, sir.
So the frequency probably in the early PAE, probably disease pathology is there, where you are treating with the RDS lung is there, a small baby. The very early PAE, probably you have to maintain slightly higher frequency. A frank pneumothorax is there, probably lower frequencies are recommended. So maybe that is the doubt he has. So basically,
Yes, sir. Yes.
if it is also when you are looking at PAE, you have to look at the lung also. So not only PIE, if it is very early stage PIE, very mild PIE is there, you should not come down on the frequency. You can stay at around 12 or 13 because the baby is small. Those frequencies, your ventilation amplitude will be transmitted better to the periphery. Whereas a big baby with resistance, with pneumothorax, probably there your frequency should be on the lower side.
I think so. Excellent answers from both the speaker. Last question. I think so. Both should take and both should answer. And later, so many people have raised the hands. We will go for them. Can we use HFOV machine during surgery? Because many times we faced a problem. Yes, baby's SpO2 was good on HFOV at the time of shifting. Or anesthetist when anesthetist is touching the baby and taking at the time of SpO2 drops, baby becomes dusky. Then they're shifted back to NICU, stabilize the baby. So, is there anything I should tell to anesthetist to use? Is there any role? What do you mean by any role for HFOV? I think so, sir is, so this is from MP, he is asking.
Oh, means the role of oscillation during surgery, intra-op, whether we could keep on HFO or not. Is that the question?
Yeah, at the time of shifting, baby will succumb. If we are shifting from that baby, conventional ventilation or ambu bagging, so they are shifting back. That is his problem. The second thing is in anesthesia, people are not accepting it. What should I do? He is asking.
Okay, I think we transferred so many babies while the baby was an oscillator to the theater, but in theater I think practically it is going to be difficult to put the babies on oscillator and then doing surgery. So I have not seen doing like that in our place in India or in UK. I know for discussion's sake we could talk, but practically it's going to be difficult to do the surgery while oscillator. Dr. Sheshagiri sir.
Sir, according to literature, whatever latest literature is there, they say that you can, but as you rightly said, there might be some practical difficulties. Your anesthetist may not be aware how to deal the baby on the oscillator and so many so forth. But according to theory, according to rule, definitely it is yes.
I think so. All the questions are over. Prashant? Prashant? 1 minute. We will unmute all the people. Okay. Dr. Sir, Naresh Prasad, please. Dr. Naresh Prasad. Naresh Prasad. Sir, Naresh Prasad, sir.
Yes. Am I audible?
Yes, sir. You, sir. Please,
Yes.
please.
What percentage
Sir,
of the
आपका वीडियो
newborn?
भी ऑन कर लीजिए. आपका वीडियो भी ऑन कर लीजिए.
ठीक.
It will save life of someone.
So, what percentage of the newborn? Hello.
Hello, sir. Dr. P V RAMA RAO.
Yes.
K SESHAGIRI. Yes, sir. Sir, Naresh Prasad, sir, please talk.
Yes.
This will save the life of someone.
What percentage?
Hello.
Am I audible?
Yes, sir.
So, what percentage of newborn recover their lung function and cardiac function after the surgical repair of the diaphragmatic hernia? And what is the usual time for the recovery?
What is the usual time of recovery?
For the after the repair of this diaphragmatic hernia surgical.
Life of someone.
Okay.
No,
So, Dr. P V RAMA RAO, sir.
normally what we do is after surgery, usually pediatric surgeons would tell us to keep the baby on ventilator for at least 48 hours. and proper plus or minus muscle relaxation for 40% and then we will be, that's what we normally do.
अगर मान लीजिए आइसोलेशन नहीं खाना जाता है तो राइस को डाल के थोड़ा मक्खन डाल के उनका डालो लेकिन राइस घी भी लेकिन घी और
Yes, sir.
मक्खन
Tell me, sir. Sir, Naresh Prasad, sir. Any other questions are there, sir?
Yes. Is there any role? Is there any role of physiotherapy in the ventilating child? Is there any role of any role of physiotherapy in the child who are under
Dr. Sheshagiri.
or
Dr.
even after
Sheshagiri,
the
CDH after the operation, is there any role of physiotherapy? He is asking.
No, no, there is no big role in the physiotherapy. Only thing is, again, routine care is more important. There is no big role of any physiotherapy.
should we monitor the environmental temperature and the humidity in the ventilating child?
Should we monitor?
Sir, what, sir?
Environmental temperature or the humidity in the child under ventilation. Should we monitor it?
We have
Sheshagiri,
to maintain.
what his question is? Environmental humidity, environmental temperature, is it matter? Is asking.
And humidity also, sir.
As well as humidity.
Sing, mute all, sing. Sing, mute all.
Naresh Prasad.
Is there any role?
Hello, Naresh Prasad, sir.
Yes, yes. Is there any role to moderate the environmental temperature and humidity in a case under in the ventilating child? A child under ventilation?
Yeah. Okay, okay. So they will listen. They will listen. Prashanta. 1 minute, sir. Hello, Prashanta.
Yes, sir. Yes, sir. I had internet issue. Now I'm back.
No, no,
sir.
no.
Okay.
No problem. No problem. P V RAMA RAO, sir. Please. There is one more question with Dr. Sir Naresh Prasad, sir. Boliye.
Is there any role of environmental temperature or humidity in a newborn cared by the ventilation?
Sheshagiri.
Sir, I think what he is asking is maybe it influences only the condensation in the limb, the expiratory limb. Maybe that is important. Apart from that, because they are in the warmer or in the incubator, it doesn't matter. The ventilator tubings, probably if the humidity is more or when temperature fluctuations are there, maybe the condensation will be more. Maybe they need to clean the empty the limb in water in the expiratory.
Ways is comfortable to the baby, sir. Even humidity, normal humidity, you have to maintain, sir. 36.5 to 37 degree, you should maintain even in the humidity temperature in the ventilator tubings. Okay, sir. Naresh Prasad, sir.
Over, sir. Thank you very much, sir.
Thank you, S.A. Rahena, sir. I think so. Over to Prashant.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Thank you very much. Totally 161 people were there in the Facebook. Sorry, 141. 141 people were there in the Facebook. Very happy. They've asked around 12 questions. And today is 141 or 142 people were there in the Zoom today. Anyhow, Saturday, I expected less people, but thank God, many people have. And Prashant, one more thing. Everybody is opposing Zoom. Many people doesn't want to log in China. You have to do something.
Sure, sir. Sure, sir.
Okay, dear.
Now, the only problem is that anyway, sir, we will discuss that. All right, sir.
Okay. Thank you, Elbudu.
Thank you, Dr. Rama Rao, sir. Thank you, Sheshagiri, sir. It's always wonderful to listen to you, and thank you for making time. in your busy practice, and thank you for making this particular topic so simple and so easy, and having patience to clear all the doubts. Thank you very much. I would like to request all the participants to join us tomorrow. Tomorrow, the same session is going to continue on neonatal respiratory chapter. Thank you very much. Have a great weekend. Have a great Saturday and a safe Saturday. Thank you. Thank you. Thank you. Bye. 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 Bye.
And Anna, thank you very much, Anna. Sheshagiri, thank you very much, sir.
Thank you, sir. Thank you very much.
Patricia sir wants our
Thank you,
NNF
Anna.
president.
Yeah.
Our
Good
NNF
evening,
president wants
NNFJ president.
I am very, on behalf of KNF, I am very thankful to Dr. Seshagiri and Dr. Rama Rao for the wonderful presentation on life support. And I appreciate the whole India has been participated in a good number. So this is the one of the state KNF is doing a wonderful activity. I am very much thankful for all the participants and the speakers and the Prashant and Dinakar. Nice of you, sir. Over to Prashant.
Thank you,
Thank
sir.
you very much, sir. Thank you.
Okay.
Sheshagiri, sir. Bye, sir. Thank you very much. Anna, thank you.
Bye, sir. Bye, sir. Thank you. Thank you, sir. Thank you, sir. Thank you.
Thanks, Dr. Prashant.
Thank you, sir.
Okay. Have a nice weekend. Bye. Thanks.